is first we mark the clavicle, so that's a clavicle. Medial 1/3 of clavicle, you will get the sternomastoid. Okay, sternomastoid is the medial 1/3. The lateral 1/3 of clavicle is the trapezius. So trapezius is actually much more anterior than we think it is. And similarly, sternomastoid is more lateral as we think it is. So 1/3 is marked with sternomastoid and trapezius. We go through a neck crease incision. Many people still do a L-shaped incision. L-shaped we have stopped out. For the last 20 years we don't do. The reason is this L extension gives very unsightly scar and always becomes hypertrophy. You don't need to do that. You can access everything. The other big anatomical landmark is the level where you will find external jugular. Where the external jugular meets the sternomastoid, usually that is C5. So that's a good landmark. If somebody has prominent external jugular, so if you see the external jugular where it meets the sternomastoid, that level is usually C5. So you don't need to go ahead of that. And so that is the level. So beyond this level, you don't need to expose. So C5 is our upper limit. The C8 and T1 usually is below the clavicle. So you need to retract the clavicle. And so the steps, before I start, basically 10 steps. First is positioning, turning the neck, non-relaxant anesthesia. So that is very important. You have to tell the anesthetist, we will be stimulating it. So non-relaxant anesthesia, head tilted to the other side. We infiltrate. So normally we take 1 in 1000 adrenaline and dilute it with 200 cc's. So you can infiltrate the distal part also. So it becomes 1 in 2 lakh adrenaline. We infiltrate. No need for xylocaine because children sometimes use xylocaine, but adults we use only adrenaline. We infiltrate and then we start the exposure. The layers will be, first you will get the skin, then there will be platysma, and then you will start seeing the fat. So till you reach the omohead, you are not going to damage any major vessels because the transversocervical artery and vein will be below the omohead, and only thing you will see encounter is the external jugular. It is not mandatory to ligate external jugular in all cases. If it is too medial, you can just retract it. If it is coming in the way, you ligate it. So that's the external jugular. Once you divide the omohead, you will see the transversocervical artery and vein. They usually run across, so you may need to ligate them if you are finding a root. If you don't find a root, a big mass, then you are just doing nerve transfer, then again no need to ligate them. But you ligate them, then you will see. So the other landmark is the phrenic will go vertically. Phrenic is the only nerve in the neck which goes lateral to medial. All other nerves will go medial to lateral. The Erb's point is basically a point where C5, C6 root, they converge. The two divisions, they diverge and two branches come out. So that's a landmark. And the omohead, the direction of omohead is exactly the direction of suprascapular nerve because we have to use the suprascapular for nerve transfer. So you retract the omohead nicely, you will find the same direction suprascapular nerve. And that's how we identify. So suprascapular will be there. Under the trapezius, we retract the trapezius 1 finger breadth below, you will find the spinal accessory. So that's a landmark. And there will be a lot of fat pad here. So you should not randomly dissect the fat. The ideal way is to raise it like a flap. So you go from inferior, medial and lateral and raise the entire fat pad as a flap. Previously we were also dissecting it and throwing it away. Then you get chances of seroma and post-operative drainage leakage is high. You raise it like a flap. Once you have done everything, you put it back. And on the left side you should be careful of injuring the thoracic duct. Right side, of course, phrenic is more important. So right side, remember phrenic now. Left side is the thoracic. So these are the two things you need to keep in mind. Sometimes spinal accessory, you need extra length. Then you can dissect this trapezius off the clavicle, slide it off, and go deep inside. So you can get at least another 2 to 3 centimeters below the clavicle. It's called Brachial maneuver, where you dissect it. So we'll go through now. We start. And quickly, the cervical rib, you go medial. So in this, we don't need to go medial. And the lateral most part of your incision is the trapezius. As it is giving branches. You can see nice branches.
Loops and loops.
Yes.
You see 1, 2, 3 branches are there.
Yes, sir, we can see.
Yes. So it is going into the trapezius. So at this stage, I will show you in the afternoon video also. So we loop this.
Loop there.
We loop the vessel loop and then keep it separate.
So where is trapezius?
This is trapezius. This whole thing is trapezius. So
Here to that?
How do you decide where to translate this nozzle? I mean, like, how to
So-
going to the trapezius?
yes. So what we do is, already it has given few branches as it curves along the sternomastoid. So it has given branches higher up here. It has given branches. So we need to divide it only after we get the suprascapular nerve. So don't decide on cutting it till we get suprascapular nerve. So first we divide the suprascapular nerve, and once we divide the suprascapular nerve, then we divide the spine plexus. So this is the fat pad which I said, and this is the scalenus medius. So now we have started actually seeing the abhi focus region. So once you do that, so this is the sternomastoid which we have defined. This is the scalenus medius, and that's the plexus. So that's the C5 root, which is C. That is the IJV. This is the scalenus anterior, and this is the phrenic. So this is the phrenic. So you see, so we have reached the origin. This is where I said this is the level where normally the EJV will hit the spine, the sternomastoid. So that's a C5. So we reach the C5. So sometimes you will find that the root is very high up and you cannot access. If you cannot access here, so one of the techniques, I'll just show you here, is that you can divide the scalenus anterior. So how do we divide? So what we do is we safeguard these phrenic first. So first we safeguard the phrenic with the loop. The most important thing is once you loop any nerve, we don't put an artery forceps as we have put here. We put a vessel clip. So you take a white clip and then just put a vessel clip so that it doesn't, no traction is given on it. So you can do this. So this is one good maneuver. You retract it towards laterally, go higher up. So here you will find there will be a small connection between the C5 and the phrenic nerve. So once you have safeguarded this, now you see the whole scalenus anterior is here. So this is the maneuver we do in thoracic outlet also. You can divide this whole scalenus anterior. Okay? If you divide this scalenus anterior, the biggest advantage is you can get very high level C5 root. Okay? So you can get right at its origin. Actually we are now hitting the vertebra here. We have reached at the origin of the C5 root. So this is our phrenic. We move away. Actually we are still not seeing the omoid. So that's the omoid now started to be visible. C5 and C6 are more vertically oriented, and then once you retract, you will find the C7 root. So that's the C7 root. So this is the C7. Let's see.
Where is C6?
Yeah, let me see. That's why I put the.
I think maybe counting C5, C6 both is here.
Yeah, C5, C6 both are here.
Yeah.
You see here?
This point again.
Yes, one second. So throw out, you go higher up. Very rarely you get such nice normal roots.
Yeah, it's a scar root. C5 is contribution है phrenic का. This is definitely middle trunk, it's upper trunk.
C6.
Yeah.
Yeah, I think C5, C6 both are here. See, this is C6 because it is not connected with the phrenic, and this is C5. So my forceps is between the 5 and 6. Yes. So this is 5 and 6. Okay.
The person needs to align.
Yes. So this is C5, C6 both in my forceps. So as you go down,
The retractor is hiding this.
Yeah, okay. These are all the data.
yes. So 5 and 6 both are here.
Yes. Yes.
The phrenic is coming from the 5.
Yes.
And the 5 is very small in this. This is the main C6. So this is our Erb's point. And these are just below the clavicle, you will find the divisions forming. So now we just go distally to show you the origin of the suprascapular. So you see now the suprascapular is actually flush with the posterior division. So this is the anterior division, small actually. And this is the entire thing is posterior division. And from the posterior division toward my side, you will find the suprascapular. So that's the sort of gap between the So you can find a nice groove between the suprascapular and posterior division. So this is the suprascapular now. Okay?
Thank you.
So you see all three are there, anterior division. So this anterior division as it goes down, I'll show you, the C7 will combine, the anterior division of C7 will merge with this and form the lateral column. So this is anterior division. Posterior division is always larger because it goes to all the shoulder group of muscles. So this is posterior division and this is the suprascapular. So now you are asking where do we divide the spinal accessory? So one of the tricks is under microscope, you can actually see now I have dissected the suprascapular from the posterior division. So under microscope what we do, we can actually go quite high up like this. Same maneuver we can do to dissect the biceps branch from the musculocutaneous when we do Oberlin trans. See how far you can go. So the higher you go, easier it will reach the spinal accessory. So if you accidentally just cut it off here, okay, so the dictum is donor distal, recipient proximal. So donor you cut as distal as possible, recipient you go as proximal as possible. So both will, so now once you divide it, I am not dividing for all you to see, we can loop this also and keep. So one small trick I find, I always use my scissors only. So some small tricks I will show you. So you take the scissor and push this inside. So you don't need a artery forceps facility. Yes, so when you pull out a scissor, it comes out. So in a smaller scissor, it will come perfectly. So this is suprascapular. So now, first you divide the suprascapular and then see where it reaches. So usually, now I'll come back to the spinal accessory to show where we divide it. So usually you will have minimum 3 or 4 big branches given off before we divide it. So now retract this. So now you see these are the branches. So this is a, yes. So there are, so these are the branches going to this trapezius. So you leave this and go distal. Many patients will have one branch coming from the ansa to the sternomastoid, which will go. That's why even many times when you divide the spinal accessory, the trapezius, the trapezius is still viable. So you can divide it, so donor distal as possible and recipient proximal. So that's a nice dictum by Susan McKinnon. She always says donor distal, recipient proximal. So you cut it here, it will come here. Here because of cadaver it is all soft. Normally it will not come over the fat. So normally we will create a small tunnel like this under the fat and then bring it through this tunnel. So that is easier to bring. Otherwise, more length is needed to cover all the fat pad. And now we show you, it's a nice soft neck, so we'll show you the C8 and T1 also.
So in the scarred plexus, what are the tricks to identify suprascapular?
So usually there will be a big mass here and will be very down. So the trick is to trace the omohyoid. So let me see where is the omohyoid here. I think we'll try to So one maneuver we do again popularized by Bertili. So so this is the omohyoid. You will find that the suprascapular will exactly follow the omohyoid. See, this is the same direction of omohyoid. So once you trace the omohyoid, this looks like a vein because it is coming through. This is not omohyoid. This is a part of the fat pad. There will be small veins here, you have to ligate it and remove those veins. Many times in functioning muscle transfer, when there is distal vascular injury, we use the transverse cervical artery and vein. They are quite sizable for doing our transfers, our vascular repair. Yeah, this looks
Transverse cervical.
Yeah, transverse cervical is a vein. So omohyoid is still a small variation. Normally, see, this is also a vessel, small vessel vein. So that's a C8, and so this is a C8 root. This one, this is C7. The T1 usually is below the subclavian artery. So now we have reached, we are hitting on the first rib. So my forceps is actually hitting on the first rib.
Yes.
So when you have cervical rib, what we do, we retract the 5, 6 and 7 upwards, and T1 and C8 you have to retract downwards. The subclavian artery will be here. So let's see. We are not seeing this because the neck is, anyway, we cannot retract it down too much.
Your hand was coming.
Yes. So once we start, we take
C8, C7, C8, T1, so one more.
Yeah, we just take this vein away. So the vein is retracted. This is a vein which normally crosses the, could be transverse cervical or could be a vessel which is crossing the.
Like a transcervical artery.
Yeah.
Maybe you can show with your left hand, sir.
Yes. So now you see all of them are there. We will start from the beginning. Abhi kariye thora sa. Kar lo. All. So this is a Herb's point. 6 structures are there. 2 roots converge, 2 divisions diverge, and 2 branches emerge. Okay, so now the subclavius will be somewhere in this not seen, it will be low down, maybe this one. This is the nerve the subclavius, and this is suprascapular nerve. So 2 divisions, anterior posterior division. Posterior division is bigger than the anterior division because posterior division will go to deltoid and major chunk all will go to the radial nerve. So this is suprascapular. So C7,
Yes.
C8,
Yes.
and T1. This is T1. Okay. This is the vessels. You'll see the subclavian vessel just under the clavicle.
This is T. C8.
This is T1. The last one. This one. So this is T1. This is C8. This is C7. Okay. And 5 and 6. There is a nerve transfer recently described both by Oberlin and many people are trying to do now. Dr. Veena Singh has also done. We have also done a couple of cases where the trapezius, the spinal accessory, you don't want to sacrifice and the spinal accessory is not strong enough. Then you can take one small fascicle from the C7 root. Mainly on the top you will find few fascicles which are going to the lateral cord and eventually to the pectoralis major. So you take those. Nice fascicle will be there and connect it to the suprascapular. So C7 to suprascapular transfer. Then you avoid damaging the spinal accessory, preserve it for a future functioning muscle transfer if recovery doesn't come. See how close the C7 is to the suprascapular. So if possible, let us see the spinal, the serratus branch. So serratus branch usually will come deep here. So somewhere here, if you stimulate, you will get the serratus, long thoracic, which goes behind. It will go in this direction, downwards, between the medius and the posterior here. Maybe somewhere here. Serratus branch. Maybe this one. Some thin, not very thick branch actually. So very thin branch. See, it is getting contribution from 7, 8, C5, all will come. So that's a serratus branch. Nice. It's very nice to see. This is a serratus, long thoracic. Going behind, see everything is on the top. So this is the 5-6 root here, and 5-6 contributing to the serratus branch, and C7 contributing to the serratus branch. So it is here, this one. This is a long thoracic. Normally it's very difficult to see because it's all behind. So if serratus is working, that means some contribution is still intact. Maybe C7 most of the time is intact. So any other questions here?
So thoracic duct you told to be careful, sir.
Yeah, thoracic duct you should not see. Basically, if you go medially in this region where this all the confluence of the vein, here only you will get thoracic duct. So don't dig superficially and around the veins. So you go deep. See, if you are going directly to C8 and T1 plane, then everything is reflected medially. You won't see all this. If you are digging at the level of the veins and the fat pad, there only you will damage the thoracic duct. If you go deeper to the scalene, then you won't see the thoracic duct. Here you will see only the artery. Vein you won't normally see. The subclavian vein goes superficial, so you are not seeing in your dissection. It is above the clavicle. So here you will only see the subclavian artery. So the scalenus anterior divides the subclavian artery into 3 parts. The first part is medial to it, second part is behind, and third part is lateral to it. So similarly, axillary artery is divided into 3 parts, by the pectoralis minor. So the other, now having done this, if you don't find it here, you are asking how to find suprascapular. So if you are not doing posterior approach and still want to find out, then you can put a small incision below the clavicle. Either you can put a parallel incision or you can put a vertical if you are dissecting below. And between the 2 heads of the pectoralis major, the clavicular part and the sternal part, that is where you will find all the vessels and the nerves going. There you reflect the clavicle upwards and then you will find it somewhere lying there. That is the reason why when it is avulsed, you cannot find it here. People do posterior approach. Easy to find from behind. So that is So this is pretty much covers. So this is what I said in the end. This whole fat pad we are not divided. We just reflect it back and cover the pedicle. So basically you dissect the fat pad from superior to inferior and medial to lateral and raise the whole thing backwards. So
Sir, suppose we have a broken suprascapular and has gone below the clavicle, where do you split the clavicle?
no, we don't split the clavicle. So you pass your finger below the clavicle, make a space, and then you go through a separate incision below the clavicle and push the clavicle upwards. Then you find it. So that's only way. Splitting is as much as possible to be avoided, because if you split, you have to plate it, and clavicular, actually cutting and plating the clavicle non-union rates are much higher than traumatic injury to the clavicle. So better you have to avoid. But if yes, sometimes we do a brachial plexus tumor in this region, or you have a subclavian artery which has to be repaired in thoracic outlet, then we have to plate it first, mark it and remove the plate and then cut it in the center. So that post-operatively, post-procedure, fixing the clavicle is easier. So, yeah. So all of you can come and see here next game.